Okay, so I'll make a start. Thank you to everybody for joining the Q webinar today, and to log on to hear a little bit about the work we've been doing in our practice in Greater Manchester related to using QI to match capacity and demand, which is an ever increasing challenge, I feel. So I'm a GP partner in a small town called Stalybridge in Greater Manchester, which is part of Tameside and Glossop CCG. And I'm also the clinical director of the Greater Manchester GP Excellence Programme, which is designed to kind of support and improve general practice across the whole of GM. And so I'm kind of putting what I've learned about QI over the years into practice, in my practice, and then trying to spread that more widely as well. So I wanted to share and also learn from you a lot today. So to tell you a bit about the project, and I guess it's a project that kicked off maybe just about 12 months ago, although you'll see from some of the data we've been looking at it for a number of years. And starting really by looking at context. So as we know, kind of all those of you that are kind of QI kind of fans, that context is such an important factor in terms of whether your project is going to do anything or not. And so I thought I'd tell you a bit about the context that the project was kind of placed within. So we're a practice of 4 partners, 8,100 patients in a kind of, I would say, suburban part of Greater Manchester, but just on the edge of the Pennines. In terms of context, we're quite experienced at various improvement projects, and have a kind of QI head ever since I went through the Gen Q programme with the Health Foundation funding starting in about 2013. So we've applied quality improvement to a whole range of different things, just trying to get processes slicker in the practice, and trying to get better at achieving targets, trying to reduce telephone calls coming into the practice. So we've got a number of team members that have been, well, all of us have really been used to looking at data and trying to make things better. So I think that's really quite an important thing to say, because some of the background and the reason you can move on things quickly is because people have got that kind of way of thinking already. And in fact, this project I'm telling you about, it may look, I mean, I feel almost like I'm claiming credit for some of it, but actually I didn't lead it. I'm telling you about it, but I certainly wasn't the leader of it within the practice. So we had quite a good context to sow our idea in the hope that it would grow. But I think what we all knew, of course, what happened in February, March last year, is that something really significant happened to the context. And I think it was that, this is me, my analogy of a plough going through a field, because it absolutely all got completely churned up, didn't it? A number of the aspects of that context change, of course, were really positive about for helping this improvement and this change in looking at capacity and demand to happen. In that, the first thing that happened, of course, at the end of March, beginning of April, was it all went very quiet. And when it went quiet, we had time to sit and think. We had that little bit of reflection time. We could step back. So that was a really positive thing. And the other positive thing that happened in terms of helping kind of change to happen is that our patients gave us permission. So they knew that life was different. It was very different for them in all aspects of their lives. So it wasn't a surprise to them that it was likely to be different at their GP practice too. And so there was more of an acceptance that we were going to be doing something a bit differently, which was good. And of course, because we were trying to be as safe as we could for our patients and for our teams, we were kind of forced to make changes quickly. So that our context was quite a good one for change anyway, but then it all kind of churned up, and actually some of those things were actually positive to help change to happen. So and when you're starting with QI, you need to have an understanding of what your problem is, don't you, before you try and fix it. And something which I'm sure all of you QI fans are batting on to people about all the time. Do you really know what problem it is you're trying to fix? And so I thought I'd present some of the things, the data that we already had at that time, kind of March, April last year, in order to get an understanding of what it was about capacity and demand and what we were struggling with. And we had already gathered a fair bit of quantitative data, and of course we had a bit of qualitative stuff going on as well to see what we needed to fix. So I'm going to show you a bit of that. This is a graph of our requests for same-day care, and it's done year on year with different lines representing different years, because of course there can be seasonal, can't it, the demand for same-day care. So we couldn't do a standard run chart for that. We needed to overlay it on the month so we could get a feel for it. And I think but even without looking at the detail of this, just looking at that median line, you can pretty much tell that there hasn't been any major change to the requests for same day care between overall all those years. So starting measuring it in 2014. So we had a lot of data about what our demand was. But this particular measure at this point, we were only distinguishing the request for same day care, and we weren't measuring how that related to the number of routine appointments that were on the system. Just for the purposes of, I didn't explain so much about the background to the project, we were just looking here at GP and advanced practitioner care. So we haven't had a look today. I'm not talking to you about kind of practice nurse appointments or phlebotomy or healthcare assistants. This is about GP and AP work. So we knew about that. We knew that whatever we'd done to try and influence requests for care hadn't really made a huge amount of difference. During various times we thought they might have done, and I did another way of looking at the data. So I looked at the median number of requests for same day care, and did it by because we had a change in our list size, an increase in our list size over this time. So just to kind of check there wasn't anything that was hidden, doing it year on year. And over that time, there have been so many new initiatives that have come in to try and reduce the demand for GPs and AP, and so first contact care. Things like we have an ability to use a minor eye complaints service locally, so that our patient advisors can book people straight in there, or we have a walk-in podiatry system. We've first contact and musculoskeletal services started. So through all these times, it hasn't appeared to have made a huge amount of difference to demand over that time. And this was a really important measure for us. This was our average wait time to the next available routine appointment. So it's something we've been really kind of sensitive about, because our same day care demand tends to go up when we've got a long wait time for a routine appointment. And this distinction that we'd always made between kind of same day and routine was a kind of rule that had kind of been, which I think it perpetuates in a lot of places and a lot of practices. And I think, as I'll talk about in a minute, I think it actually was a little bit of a barrier to our thinking. So we'd, over this time, you can see we've done various initiatives, and overall it looks like some of them have been partly successful over a short periods of time, and then the wait time's gone up again over that time. So our wait time was running around about 20 days, and then we did work better, and it came down to around a kind of 15 days. And we say average wait time partly because we really kind of really respect continuity of care. And if you, all sorts of different measures, aren't there, of access for general practice, and people do sometimes do it's your second next appointment or your but the problem is you might have your kind of your registrars, or if you've got a locum in, suddenly your figures look amazing because they've got loads of capacity because people didn't particularly want to see them. So we would make it that it's the average wait time of each doctor. So each doctor's wait to the next appointment, all average. So if somebody's running with a 6-week wait, which fortunately didn't happen, but if they were to, then that would really impact the overall figures. So that's our average wait time. So we weren't particularly happy with that. And then this is next, this was this year. So that goes up to 2019, and this was the first part of this year. If you can see, this graph finishes in March, when of course everything changes. And despite, another initiative to try and reduce the average wait time, when we briefly got it down for a few weeks, down to around about 10 weeks, it soon goes up again. So that we really weren't happy with that. And there was the qualitative stuff. So the fact that we knew when we were with people in those routine appointments, we knew that we were seeing people who had waited a long time for something that could have been dealt with in a 5-minute phone call, or who'd waited a long time, and if we'd known what they were going to be, what they wanted to be seen about, it actually warranted something much more urgent and should have happened more quickly, and so they shouldn't have waited. And similarly, we were seeing people on a kind of same day service that could have gone elsewhere, and we've all got this experience. I'm sure this this is shared by everybody. We did go through a system of measuring that for a short period of time, but there's nothing really to show other than what you know. We were making the right call. And there were also really complex protocols that we'd install. So for our patient advisor, when people phone in, to try and these initiatives to try and manage demand, that if somebody calls with this, you can direct them here, or and it's it's really difficult for everyone to hold it in their head. So we didn't think we were getting to see the right people in the right seats at the right time. So that was the problem that we wanted to fix. Okay, getting started. Clearly it's about getting your people there, isn't it? We all know anyone that's implemented any QI, it's often, it's partly what you do, but it's very much how you do it, whether you end up getting the right kind of impact or not. So conversation started, and it was led by another partner in the practice, who got a team together that was very heavy on frontline phone answerers. In terms of the people in the team. So he was the only clinician doctor in the team. And then we had reception manager, a patient advisor, practice manager, who they were all the people that were taking the calls. So in terms of accessing practice, they're absolutely crucial to this. And then started having conversations across the wider team as well, to try and get that kind of shared understanding about what problem it was that we were trying to fix. And to start gathering ideas together. And I think this was the shared understanding in the end. So this was something that the partner that was leading it created when he was communicating it to the wider team. So after their conversation, so we all knew that our patient satisfaction rates are really good. So despite that long wait time to routine appointments, we were scoring really highly on GP patient survey, on friends and family, on NHS reviews, all sorts of things where people were pretty happy. And the routine thing meant that we knew how many people we would be seeing on each day. There was that reasonably predictable. They were placed into slots, predefined slots, and we felt all our safety measures were pretty good, that we were pretty safe. But we really weren't happy with this next available GP appointment average at all. And we recognised that built in some kind of inequality into systems where people who can navigate or are persistent are more likely to receive responsive care. And those particularly, we found on looking at our kind of qualitative data, that the people who had waited a long time for something which we deemed to be much more urgent. So for example, something as simple as a breast lump, and somebody's waited to see you for that. We recognised that bit of the conversation with the patient advisor, which is what we call our reception staff, they phone to book an appointment with me, for example, and they're told when it is, and unless they express some kind of dissatisfaction with that, they're not offered anything sooner. They weren't being offered anything sooner. So if they'd said, oh, that seems like a long time, then they would be offered the same day service. But unless they expressed a dissatisfaction with it, they weren't offered that same day service. Our same day service would have mopped up anybody who felt that they couldn't wait till the next available routine appointment. So that really builds in, and it had built in an inequality where people who were kind of less self-assured or less assertive were less likely to express that dissatisfaction, and were going to put up with what they were given, basically, even though we did have capacity to also offer same day response. So yeah, so it was difficult, and it was difficult, I guess, because we all recognise this, I think, when COVID hit, is that the change from having a fixed time slot to do something in, to actually having a more flexible time, so that you could, some things would be quick and other things you could take as long as they needed, was really important for managing complex patients. So that was something that was recognised. So this was a kind of shared team understanding. So obviously we'd map it, wouldn't we, being into QI. And this was our patient access kind of system before we moved to COVID. And one of the things that really struck us when we mapped it was the huge numbers of ways of information came into the practice about care that was needed, and the level of complexity of that. So the self-booking site that was opened via patient access, people would sometimes email the practice email address, and they'd walk in to try and book appointments. They'd phone in. We just started to pilot the Accurix online triage form at that point, just pre-COVID. Some people had got hold of GPs' personal NHS email addresses, and so were emailing GPs, which is always very scary when it's buried amongst all your other more kind of business kind of emails that you need to respond to. Then there'd be the queries from other professionals, kind of district nurse queries, or people, or mental health workers, or people who wanted ours. Some patients were like writing handwritten letters to the GP and writing private and confidential on the envelope, which meant that envelope was going in the doctor's tray in the office, and if they weren't in for a couple of days, or they would be buried amongst paperwork because that hadn't actually been opened or recognised that was just a request for care. There's the patient access message that people can do via their apps, or they would, when they submitted their repeat prescription request, they were allowed to put a note, and they might put something on that note saying, please can the doctor contact me about blah, or if they were still bringing in their green slips of paper to request repeats, they might handwrite something on there. And so, I mean, just kind of a massive numbers of ways that patients access care. And we really recognised that was a bit of an issue. So we marked on here where the couple of the blue circles are where we think that that's an inappropriate delay. And the red triangles with the cross was an indication where we often got very poor quality of information. So we couldn't match what we needed to be offering with that demand kind of properly, because we didn't really know what was needed or what the urgency was. A big problem with the self-access booking, even though that was obviously quite heavily promoted nationally, and we won't have been the only people that recognise this, is that we have no way of navigating or determining how urgent or not, or whether we're even the right person to answer that request, because the person's booked themselves directly into a slot. And as you could see, they were only routine appointments that would be open for that. So they would be booking themselves into something 2 or 3 weeks hence, even though their issue might have needed to be dealt with more quickly than that. So that caused a lot of inappropriate delays. And so those messages would come in, our patient advisor would gather information, they would use their skills, and then they would be booking appointments at that point. I think I've got a map late in a minute which shows you a little bit more about what we tried to move to. Okay, so our aim, trying to reduce wait time for routine care to less than 24 hours was the aim, but at the same time meaning that we could finish work on time and stay sane. So we decided we would try to get the same day's work pretty much done today, if that was appropriate for the patient, for that to happen, and also try and stay sane at the same time. Not an easily measurable target. Okay, so but we did obviously have some measures in there, how we were going to do that. So outcome measures, really easy outcome measure is what's the wait time for routine care. So we've been measuring that, haven't we, as you could see from the previous data, for ages. So that was an easy one to continue to measure. We could easily tell each other whether we felt we were getting home on time and whether we were still happy at work. So that was a qualitative measure. But then we bunged in some process measures as well. So things that we needed to know to try and match, because if you're going to get this right and try and deal with the same, with the demand for care when you need to do it, and stay and be able to go home on time, you need to know how many contacts clinicians can manage, so you can get the right numbers of clinicians in the building, or obviously maybe working remotely, but doing the work at any one time. So we needed to know that, how many contacts can each clinician manage and still feel they're operating safely, and can still be happy. And how many contacts are coming in via online access was a process measure we did, and we recognised that was quite an important way of getting the right kind of information quickly, by actually having that coming in online. Numbers of consultations per week. So this was a kind of partly a process measure, but also maybe partly a balance measure, because there was a fear that the easier you make it to access care, the more care will be requested. And of course we know in our non-medical lives that happens, that we used to be able to not know stuff, but now because we can Google everything, we want to know it all. We'll access that. And we used to be fine waiting for our next time we could go to the shops to buy something, and now, you know, we order it online and it might arrive the following day. So there is a sense that maybe making something more accessible increases that demand. So that's what we needed to measure as well. And then balances. So in that desire to try and meet people's needs or their wants swiftly, are we destroying our long-term relationship-based care, which is something that is actually really precious to us all, that our patients are still out. They're not tasks or pieces of work that need to be done. They are actual real people who need an ongoing relationship with a clinician who will you know, that relationship will make things, as we know from the evidence, that it will get better quality care. There'll be fewer admissions, there'll be greater satisfaction, and that's been precious to us. So we didn't want, whatever system we designed needed to have continuity at its heart, as well as meeting demand and matching that with capacity. And also, what do the patients think? And I'm challenging the group to you all to think about that for us at the end. And because we were very well aware that when you change something, especially in the turbulent times that we've been going through, is that initially your patient feedback might be coloured by just the fact that it's a change and not what they're used to, because all of us feel more comfortable with what we're used to, and it can feel a bit of a challenge. So having to gather really useful patient feedback is important, but we've struggled a bit with it. Okay, so we needed a bit of a new map, which got rid of some of the things. So we got rid of the patient self-booking, and that switched off. And I know we're not the only places that have done that. I think it would be, I'm not sure I'm aware of anyone that switched that back on since COVID, but that may well have happened. I'm sure anyone listening will be able to tell me if they have. And we're not allowing patient care to come in through Gmail and through GPs, NHSnet email accounts. I actually generated a false, I'm telling you all my truths now, a kind of fake auto response. Obviously it can't be set to auto respond, otherwise everyone who emailed me would get it, but it looks like an auto response which kindly directs somebody to the appropriate channels to access care, and explains why the doctor can't do this themselves, because to try and switch off that lack of safety. And then we empowered our patient advisors to gather information. They're already pretty good at gathering information, actually, to be fair, but we empowered them to really understand the questions that are asked in the Accurix online triage system, which is really very much about it covers things like what's the patient hoping for as a response as well, and it's worded in a way that actually people do seem to fill it in. I'm sure there are other people who've got similar experience of using Accurix online triage. They're very simple questions, and they're not dissimilar to the Ask My GP ones, but they're very, very different from say the Egton online triage, where it's all disease and symptom specific. And this is much more kind of about the person and what they're experiencing and what they're hoping for from the practice that day. So we're making things a lot more standardized so that the information coming in is better. And they gather, and so that information is gathered. And then the patient advisor, the little box with the green circle, is that this is the role of our patient advisors to decide on which box to put something in, on what's the most appropriate box. And if you bear in mind that those boxes are never routine appointments weeks down the line, they're always within the next 24 to 48 hours that they choose. So they need to make sure they continue to do the navigation that they've been really good at. So because they've got information, the range of things that they can direct people to themselves. We've even got a system locally whereby any woman over the age of 40 who reports a breast lump can be booked straight into the 2-week wait breast appointment straight by our patient advisor, and doesn't need to come through another clinician at the practice. So there are a number of good schemes that have been ongoing, and this really empowers our patient advisors to use those schemes as much as they can. And then they've also got some protocols that they can use themselves. So for kind of simple medical conditions, in terms of advice, they're allowed to give by protocol. So if they can't do it themselves, and it feeds into those into the next 3 boxes in terms of what consultation they are arranging. And we've tried really hard, it's been an interesting thing to change, but we've tried really hard to get rid of the word appointment, which makes seem a bit weird really, but we recognise that that appointment is a bit of an odd thing, because an appointment kind of almost presupposes that something is a time when 2 people are going to meet or something, and you've scheduled it and they've scheduled it, and it seems a little bit inflexible. So we've called them consultations rather than appointments, and that's an ongoing thing. It's kind of a slow burner how effective that is, and whether it's been necessary to change that terminology. But I mean, I think on balance it probably is quite helpful. So they basically arrange a consultation, and I'm going to show you, for anyone that uses EMIS Web, what that looks like on our scheme, and those who use different medical systems, obviously it would look different on yours. But everybody's on the same page of it is the traditional appointments book, but every clinician who's operating on that kind of way, so our APs and our GPs, all look at the same screen every day. And then there's a list which is called the pool, and then each individual clinician has got what's called their green list, and this is where we wanted to build in the continuity. But it's all, I'll probably have to show it on the EMIS screen because we're looking a bit complex at the moment. So so what we wanted to really also do away with is we wanted to do away with hidden work, which was quite an important way when you're matching capacity and demand. It's not just about those consultations or what used to be appointments, is it? As any of the clinicians on the call will know, it's about all the work that's buried in your tasks or in the letters that you read, which actually require some patient care. Phone call to a patient, a change in a prescription, a discussion about side effects. So all those tasks are now outed. So we don't use, we no longer use individual GP task lists, apart from very straightforward, for your information, this person's gone into hospital, or this person's died, or where they know that there's absolutely no action that you'll need to take. And so I might get about 1 or 2 tasks a day maximum now, and they're never things I need to do anything about. So it doesn't matter if I don't look at them for a week usually. Anything that requires me to do something in terms of engaging my brain about a patient will appear on the screen, on the consultation or the appointment screen, even though we're getting rid of the word appointment, and EMIS isn't getting rid of the word appointment, so I'll call it the appointment screen. So everything will appear on there if it needs some kind of action. And if it needs some kind of action specifically from me, that will go on my individual green list and not in the pool. If it doesn't need to be me or an individual clinician, it goes in the pool, and we all pick from it. So I will show you what that now looks like. This is what we started. And remember, this is the QI approach, so we were testing out new ways. So that's really important. And this was a guidance for our patient advisors. So not everybody fills in the forms online. Quite a lot of people, and we're not in a particularly digitally savvy population where I work. So plenty of people still phoning in or walking in. So they're asked the 3 questions. They go through the same filter. Is this a service that's for us or not? Can they deal with it themselves, or should they? I just need to be able to see my screen over here. So yeah, these are the different places that they put them. So they put them either on a GP's clinical list, and that's things that need a clinical brain, for which a preference is stated, or where continuity is important. So our staff are pretty good at really knowing who belongs to who, and so they will put them on that GP's list, or it goes into the clinical pool. That's for things which need a clinical brain, but there's no preference who it is, or it's urgent and the person who should be dealing with it isn't in. So although this box just says or urgent, if it's urgent and continuity is useful and that person's in, it would still go on their green list. But if it's urgent and that person isn't working in the practice that day, then it would go in the pool. And then the personal task, as I mentioned, it's literally just to let you know, can I clarify, can you tell me that they're not about patient care. No patient care delivery happens through personal tasks. And then we also have a practice pharmacist, so medication queries would get put on his green list. Okay, right, so this is just a little bit of a picture about what it all looked like. This was basically getting ready to launch it in September, what the new screens would look like. So the pooled clinical list, so people need care, it doesn't matter who delivers it, continuity isn't important, and they've not expressed a preference. Now, initially, you can see these had little time slots, but I'll talk you through a little bit about the PDSA tweaking cycles that we did, but we have since ditched any timings at all on any of the lists. They've gone. And then the different GPs clinical task lists. And this was a new way we tested out a few different ways of doing this in colours. So we worked out, which I'll show you the data in a minute, we worked out how many encounters would be comfortable to manage without going mad and different for the trainees. They would have a lower number, or for trainers that were supervising that day, they would have a lower number. And then we had to reduce that slightly because people would also be needing to work from the pool. So we tested out initially a green list of 10 and then a red list of 5. And the red list was, they're allowed to use those, but if you're going to use a red one, you need to make sure you bring us an extra cup of tea and be really nice to us because we'll be a bit stressed. So we tested it out using that kind of model, that there would be like an overspill, that it's fine, you know, if you need us, you really do need us, and if it needs to be me rather than put it in the pool, that will be fine. But everyone will be aware if you're moving into the red zone that you're not going to be spending that much time in the pool. So that's how that worked. And then any of those people on the pool or on the green list who needed a face-to-face examination appointment, they would be brought into the face-to-face. That's the box, which you can see on the far right in this drawing. And that would include visits, and that would mean so we all know who's seeing people and helps us to pace out people so people aren't all arriving at the same time, so that the face-to-face ones do get a time slot, and then we would put after the slot who's going to be seeing them, or if it didn't matter who saw them. So that would appear there, but I think I've got a screenshot in a minute of what that looks like on the EMIS screen. But the tweaking was incredibly important because and we needed everybody that was starting to work within the system to know how important the tweaking would be, because a lot of it was based on kind of educated guesses, but we didn't know how it would feel. We didn't know what the numbers would pan out. So there were educated guesses because we did have some data, obviously, that we were basing it on, but we knew that we needed to tweak it. So we did lots of Zooming to talk about it. I think that we had weekly chats about it to start with, and then we also had on our shared drive, we had a Word document like table where people could just throw in questions. So rather than perhaps if we hadn't done it in a systematic way, one patient advisor might ask me, oh, what should I do with this one? And the very fact they've asked that question has meant that it's not been clear to them. So we would capture that. I would say what my opinion would be about where that might go, but I say, but remember, it's not my baby, it's everybody's baby. So let's put that on the list of queries, and then when we next meet to talk about it, we can all decide where that thing should go, what we should do with that particular aspect of care. Should it go on somebody's green list? Should it go in the pool? So whenever there was a question asked, we captured that question as meaning that this is a bit of uncertainty, we're not sure yet, maybe nobody's sure. So really encouraging this whole scheme to be everybody's baby was really, really crucial. And so this is, I've actually just cut and paste this. This is the first couple of pages from when we first started tweaking it out. Yeah, so we didn't start it in September, we obviously started it in July because these are the dates, the real dates. So things like if the GPs are adding face-to-faces, they're putting them on the personal clinical list rather than the face-to-face pool. Why is that happening? We thought we were all going to go on the face-to-face pool. Maybe there's a good reason, maybe. So then we talked about what we should do with that. Task cut-off list, should there be a cut-off? There's all sorts of different questions that arose. And then when we meet together on the Zoom, we would then write down what the conclusion was once everyone had talked about what they thought should happen. So and sometimes it's related to specific patients. So this was the type of I guess this is part of the study part in PDSA. So this is what we observed, and then the questions that arose from that, so that we could then act upon them. but it's not always plain sailing, although this is not, it's not the right metaphor, is it? Because this is clearly a whitewater raft, not a sailing boat, but it wasn't all plain sailing. And I think our most challenging moment was during some of the measuring quite early on in the system, when we looked at how we let it run for 6 weeks. And during that first 6 weeks, we measured how many clinical encounters, how many consultations each clinician was managing per session. And that was turned out to be incredibly important data in terms of doing that crucial bit of matching demand with capacity. It was really important that we knew how many people could comfortably do. But oh my goodness, that was quite a threatening thing. Even in a team that are used to being measured and working and have always shared stuff, all of a sudden it started to feel from some of the people being measured that they weren't being trusted, that they're being measured and therefore not trusted. And if they were doing fewer consultations, they weren't doing it as well. They weren't working as hard as other people. And we had a bit of a moment of catharsis, really, which I mean, in the end, it was positive in the end, and we all and we grew stronger as a team, I think, as a result. But it kind of taught a lesson about making sure everyone agrees the measurement strategy and what you need to measure before. Because there was a range in terms of some people comfortably being able to do 10 to 12 per session, and some people being able to do 18 to 25. So, you know, there were differences, but I think that needed to be kind of reflected in then how we match the demand with the capacity. So it was every intervention can have side effects, and that had there were a few tears shed, but all was well in the end. So this was during the first 6 weeks of our measuring. This was our daily average of patient consultations. Remember, that's what I'm calling them now. Our daily average of patient consultations. So this is really important when you know how many people can on average do, and then you know how many our business manager knows how to juggle people's timetables. Now, we are lucky enough to have some members of our team who are really flexible, who work less than full time, but they don't necessarily mind when those sessions are. And I know not every team has that luxury. But that's been really, really helpful at knowing when to move people around according to who's in and who's not in. So we use that daily average and the numbers of consultations people could comfortably do to match it. And this, for those that use it, would be more interesting for people who use EMIS Web to see how the screen's set up. And I couldn't capture the whole of the day, because if you imagine the green ones are each are the individual clinicians, but this gives you a feel for it. So on the far left is what's called the clinical pool. So things that come in that do need a clinical brain, but don't necessarily mind who they have, or where continuity isn't a problem, and where continuity isn't a problem. So they would appear on that left-hand side. The next thing is obviously not our thing. The next one is the face-to-face. So that if they need to come down after they've had the consultation, they need to be seen, they would appear. And if you can see a knee injection's gone on there, because it's really difficult to do that over the telephone. So they would go on that face-to-face. And then the next one is not ours. Clearly, that's 111 GP Connect. So they can book people directly into that. But we treat that just in the same way as we do the clinical pool. It'd be easier for us if they could just book straight into the clinical pool rather than giving us another column of places to look, an extra level of complexity. But apparently that's not possible. And then you've got the clinical lists. So you can see each doctor's got, I'm fortunate, I've got a surname with the early part of the alphabet, so I don't need to track too far across the right-hand side to get to my list. Some doctors that aren't A's or B's have to track down that way, but that's where you'd get your people for whom you need to speak to. And that's, of course, where you put your planned follow-up as well. So it's always been a bit of a beef of mine with the old style advanced access and phone on the day, and you can't book routine appointments ahead of time, is that actually we know some of our really complex patients, especially related to mental health, planned follow-up is crucial to ongoing relationship-based care. So that's where you can put your planned follow-up as well on those lists. So that's what that looks like. But anyway, so some of the tweaks, so talk a little bit about the tweaking. There's been all sorts of things gone on. So we've got rid of the time slots in the clinical pool. We've also divided it into morning and afternoon. because psychologically, this was a big thing for me. Psychologically, if I can still see work needing to be done, I won't break off and have any lunch. Whereas if I'm actually told, right, this is the break of the pool, now you've done the mornings, go have a break, I found that psychologically much better. It's all arbitrary because the work will get done eventually anyway. But I found I couldn't relax to stop work without without it being told to. So that was one of the tweaks that everyone went along with, and that seems to work fine. So we have morning and we have afternoon, which has been quite nice. Anyway, outcome obvious, isn't it? So the only reason it's not now 0 is because for continuity issues, you know, one person, if somebody wants to see somebody and they're not, or speak to somebody and they're not in that day, but it's not that urgent, they'll put them on the green list for the following day. So that'll be more than 0, that'll go to a day. And to account for certain holidays, we'd usually put people in the pool if someone's off for a week or 2 weeks. We're not going to put them in for a slot 2 weeks later. We'll try and get that issue dealt with. So that's the outcome in terms of that data, but that's obviously not a surprise, because that's what the whole system's designed to do. So we've gone down from any waiting time at all. This is one of our, as I mentioned, one of our process measures. The information that comes in online is the highest quality information that we get in terms of deciding what needs to happen with that query. And that's gone. I've only got 3 months data because I didn't trap it and capture it, and I could probably ask them to give me beyond there, but even if you look since October, November, December, it's on a steady increase, which is really, really positive, we think. But what else happened? So this is, as anyone knows who's listened to any QI stuff I've done before, we've been working on reducing our monthly incoming calls for some time. So this data goes way back. So this is the data for the preceding kind of 18 months. And it's clear that our incoming phone calls have gone down. And now I imagine that's mostly because we've got the online way of accessing care now, which is great. But it may also be that people aren't phoning so often for cancellations for appointments and things because their needs already been met. But the number of abandoned calls has gone up, and initially we were a little bit puzzled about that because we just got really lazy on the phone. So we got fewer calls, but we're just not bothering to pick them up. But actually what we recognise is we changed our answer phone message as part of this whole PDSA thing as one of the tweaks, so that it says one of the options is to go online and request care that way. So people of course hang up because they're going to go online. And so we reckon that was probably the cause of our increased abandoned calls. But then, if only somebody would stop moving the goalposts. So one of the things that we were measuring, as I mentioned before, is has our demand gone up as a result of our project, and this is the data on that. So quite demoralising. The dip to the dip to 412 that you can see there was our practice COVID outbreak, which happened in October when we had a third of the staff off, and we were told to close the building by public health. And so we did close the building. We still operated equally as we did before remotely, and also had local practices. Our PCN practices were seeing our face-to-faces, but we sent a text message out to all our patients, letting them know what had happened. And asking for their patience during this challenging time. And our patients are just lovely, aren't they? It'll wait till you get back. So we told them that we were experiencing some challenge, and so they all went away for a week and then came back the following week. So this is challenging. But what does it mean? It could mean that, like I mentioned, you build a lane on the runway or on the motorway and you get more cars. It could easily be that. It could equally be that we're getting better at recognising what care is. So all those buried tasks, all those letters that require you to phone a patient or that you to deliver some kind of quality care is now being recognised for what it is and is going on those green lists. So this is what I think may be happening too. And the heartening thing is it does appear to have stabilised out again a bit of late, but it obviously is being ongoingly measured. So it could be that. Watch this space. What's left to do? So this is opening for discussion. Meaningful views. So we have a brilliant patient participation group. They're absolutely fab, and they continue to have Zoom meetings every 4 to 6 weeks, which is great. So they give us they do help us to tweak these things, and we ran any changes that we made, we ran through them and gathered their ideas as we made them. But our challenge is that they love us, and so everything we can do, we seem to be able to, you know, from their point of view, we can do no wrong, and we know that's not right. We know some people will struggle with the survey, so that's hard to gather that, and also so what we were doing is just having qualitative discussions with people as they access the service. How was it for you today? Almost. We didn't switch our automatic friends and family back on because it was really difficult to know which group to switch it on for, and the way that the system's set up, you need to have had a timed appointment slot in order for that text to go out. So that's really difficult. And also because some aspects of care might involve you not actually speaking to a patient, but reviewing their records, giving some advice and texting them, then the friends and family would say something like, you've been in and seen your doctors today, how was the experience for you? And that, what, you know, it was just too inflexible, too difficult. But if someone solved that one, we'd love to hear it. Promoting use of the Accurix. So we've still got a piece of work to do on that. We do find the information is heaps better. In fact, if I see on the pool that the information is coming through Accurix, I immediately feel more drawn to doing that query, because I know I'm going to be able to be more prepared in advance about what the conversation is likely to involve. So that's I think that's going to be really useful. And we're still hunting. I mean, I've been hunting for years for a useful and easy to measure continuity marker that's bolted on properly onto the medical record system, such that you know what proportion of encounters with the practice happens with the same clinician, and don't think it exists. I know that certain medical systems have got them, but I certainly don't think it exists in EMIS Web. But if somebody knows different, I know Mark's on the call and as part of the continuity group, but I still don't think there's an easy to measure one that can be measured in real time. So love to open that up for discussion. I'm going to stop sharing now so I can see your faces if you've got your cameras on.
Great, thank you so much, Joanna. I can't believe how much you've managed to cover there in 40 minutes. And it's
probably because I talk a bit too fast, so apologies in retrospect for that.
I think it's one of these big topics in primary care, isn't it? And one that I think lots of primary care teams have tried to sort of overcome, but you can tell from the work that you've done that there is no easy solution. Actually, it's an ongoing piece of work, isn't it? And something that you've been focusing on for the best part of 5 years, looking at the data that you've been gathering and all the actions that you've implemented over the course of that time. Would you agree?
Yeah, absolutely. I think the disappointing thing is all the things that we'd tried had never made a difference. So that I think the change to, I suppose, it became known as total triage, didn't it, where you get your most experienced person deciding what needed to happen. But of course that's not what it is it? It's because it's not triage by the clinician, because you're dealing with it. It's a consultation. It's not a triage conversation. It's actually the consultation. But that everybody gets that within kind of 40 hours was such a massive dramatic change that I think we would have struggled to implement without there being COVID, without the push, without the force to do it. And I know that's true of lots of practices, but I also hear now of lots of people slipping into a combination of an old system and the new. And I mean, maybe people have found that works really successfully, but I just get a sense with us, we'd go back to those old ways of 3-week waits.
I've been trying to keep an eye on the chat. So it's great news. We've had so much representation here today. We've got people from Belfast and Wales, and Lindsay coming in from Nova Scotia. And we have got quite a few questions for you, actually. Joe, I think you've been asking about the data itself. So how have you actually managed to collect this data, especially around average wait for appointment time? And Camille had something along the same vein around how do you measure demand. So I think when she's tried to look at this, they've managed to capture demand that has been met, but how do you know that you're actually capturing all the demand that is there in the system?
Okay, so I'll answer the one about the average wait time. We had a member of the reception team tasked with doing that every Friday. So we set up like an Excel template, and they would just put in which doctors were in, count the number of days, and just put it in, and it would calculate the average. And she plotted that on that run chart. which that's a task that doesn't need doing now because it's, you know, it's always there. So that was that one. The one about same day was interesting. So we found, because of the way our system was previously set up, we could measure it, but I appreciate the fact that not everyone can measure it. And that graph that you saw with the same day demand, we always had a kind of pool system called the same day doctor service. And the only rule that you had to fulfill to go on there is that your issue would not wait till the next available routine appointment. So you didn't have to say it was urgent or whatever. You just were given, send when the dates were for the next routine. And if you felt your issue wouldn't wait, you were put on there. So that meant that there was nobody turned away. Obviously, what we don't know is those people for whom the phone wasn't answered. All those people for whom continuity was so important for them, they would rather not be seen at all than be seen on by somebody else who might have decided not to go on that same day screen. So you're absolutely right, there may have been some unrecognized demand in that measure. So it still could be a proxy measure, but I suppose at least it's a measure that probably captures most of it. So the current measures are much easier. So the way we've set the screens up now is that the EMIS GP workload tool that's built into the system does the measuring for us. So we've got everything is recognized as a consultation within that, so we can see our daily. So that final graph you saw with the weekly demand apparently going up, although hopefully it's now stabilized, that comes from the GP workload tool built into EMIS.
Joanna, I'm not sure if you can see, there's a question from Karen, and I think you've actually raised this within your measures as well. So how many contacts a day is safe? And do you actually have a cutoff in terms of number of patients per day or per session?
No, we have no cutoff because we'll never be able to keep the 24, 48 hours if we ever have a cutoff. So we use previous data to match capacity with demand, and with the kind of premise that around about 15 patient contacts, consultations per session is safe. But if we absolutely have to, particularly if we've got some particularly fast workers in the building who can seem to be able to do early 20s without going too crazy, but if we all pull together and there's enough people in, we can go up to kind of 18 or so. But we've not need, if you remember, we're measuring it and basing it's more stable than you think it is. So you can, it feels scary to have it as unlimited, but we have had it as unlimited ever since it started without going too crazy and without having to stay late.
And then we've got Will, who's asking about how do you differentiate between follow-up and new demand, particularly because there is variation among clinicians, isn't there, in terms of the notion to bring patients back in?
We don't actually, Will. We don't make any distinction between them. Clearly, your ability to follow up somebody is sometimes one of the crucial reasons that we stay sane, isn't it? If you felt that you were somehow criticised for needing to follow up because somehow that meant you were a weaker person or when in fact it might mean that you give a toss. It means different things to different people, and I think there's a huge amount of trust. Now we've rebuilt that trust, having measured people's numbers of encounters. We've rebuilt that trust. We just trust each other that it's whatever is right for you is right. I guess, would that be different if you looked 2 or 3 weeks ahead and your colleague always had a full green list and there were always things that they'd put on themselves? Possibly. That hasn't happened, so we've not had to worry about it. So that bit's not broke, so we won't try and fix it.
Katie, I wanted to bring you in if possible. Katie is an expert by experience and is also a key community member. And I know that you were keen, Joanna, to get some thoughts and patient feedback. So Katie, if you're there, do you want to?
Yeah, I was just going to say, about making contact when you're really struggling with your mental health, that it's really, really difficult to pick up the phone. And speaking to a receptionist, I mean, there's been a number of times when I haven't been able to do it. So I think
I think that's absolutely right, Katie, and that's where this Accurix portal is really useful. So it acts a little bit like you being able to individually email your doc. And so on our website, you just click on it if you want help with your query, and you say who you want it to go to. But it means there's a single point of entry for me, so I'm not looking in loads of different places and worried about missing an email from a patient. So what will happen is that will come into the normal portal. Our patient advisor will see that it's for me, and they'll put it on my green list. Yeah. And it'll go on the green list with all that information that you've given me as well. And then if it's a quick, like you're asking a quick query, say if you're thinking, is this, I've just got started this new med, could this be a side effect, or I don't, you know, it's not going well for me at the moment, can I have I really could do with a fit note, and your doc knows you really well, it might not even involve a conversation. So I might text back saying, yeah, no problem, here's your fit note, or yeah, I'm absolutely happy to do that, did you want to chat as well? And you could reply yes or no. So the level of it being about centered on the person with the needs, not centered on the system with the block boxes that you have to fit in with. These green lists are incredibly flexible. They can be whatever that person that's got the need needs.
Thank you.
Just to try and break in that, you've got to have an appointment concept.
Can I come in with a final question?
I'm really interested in the continuity. Somebody's feels they've got a continuity measure. It's brilliant. So maybe we should take that offline. Is that Joe? I don't know if you can switch your camera on.
Mark and Joe.
Mark and Joe. Okay. So that's something that will bolt onto EMIS and do that easily for me, because I will definitely.
Yeah, we've just piloted it, and Julia Martineau can let you know about it if you want.
Yeah, please.
We're happy for that to be shared and people to try it out. It's an Excel file that works really well, and I've been amazed in my own practice to see how useful it is. I'll be able to comment on it as well, but it's really good.
The sadness here is that we can't measure it before and afterwards, so we can't see what we were doing, to see if we've made things worse or better. But sorry, Joe, you were just going to say.
No, it's just adding, because it's all part of the Health Foundation programme for improving continuity of care with general practice. All of this will all be available to everybody to see the results of in the summer of this year. But they're testing several different ways. So there is a slick measure and one that also looks at usual provider of care that one carer using down in Bristol, and in Morecambe Bay we have linked a business intelligence dashboard to EMIS in terms of its exports and gathering that information in a different way as well. So there's a few different ways that we're testing that out, so it's not just one way, but we're all finding them useful and kind of sharing between each other. But it will all be available for kind of general practice to see in the summer, the results of all of the programme, and also access to some of those resources, as well as a toolkit. We're full of QI tools as well for improving continuity of care.
Brilliant, thank you. I'm looking forward to that. Sorry, Ramya.
Yeah, no, my final question to you, Joe, was, do you feel like you've succeeded? Because I guess the question that you asked was, can we offer patients the access they want? Can we maintain continuity of care? And also make sure that our staff are well looked after? And would you say that you've managed to do that?
I hope so. The missing bit here is knowing genuinely whether it's working well for our population. It seems to be, but then people who've obviously had a fantastic service and feel they've had their query dealt with so much more quickly than they thought they would, and perhaps more likely to tell you that. We obviously we would gather grumbles. That would be something we'd be gathering anyway as part of PDSA, and there have clearly been a few grumbles. But then some of that's not been generated by us or our system. It's been generated by the mainstream media, who are telling people that they can't see their doctor, and we're going, when did we ever tell you that we couldn't see you? So, you know, that's the challenging thing. Until I know that it's meeting what people what they need out of their GP surgery, I don't think I can answer that for definite yet. But we are pretty happy with it. Still being tweaked, but we're pretty happy with it.
Great, thank you so much. I think we've run out of time. Jess, I want to finish off with a couple of bits of information. So I've posted an evaluation form, which just take a minute to complete. It'll be really helpful for us in terms of shaping future events, but also helpful for Joanna as well. And I also wanted to let you know about the next event that we are running. So that's going to be on Tuesday, the 2nd of February. And we've got Will Bostock, who's going to be talking about podcasting for health and how we can use that to extend the GP consultation and enable patients to self-manage more. So it sounds like it's going to be an interesting talk, and hope to see most of you there. Thanks, everyone.